Mark, if you want to introduce yourself to anyone who might be brand new, because we've gotten a lot of new people joining us from the last month or so, or since we did our last webinar. And then I can start with the questions for our Q&A session.
So, hello everyone. My name is Dr. Mark Horowitz. I'm a training psychiatrist and researcher. I'm now an associate professor of psychiatry at Adelaide University, and I also work in the public health system in England, where I run a deprescribing clinic, and I'm one of the co-founders of Outro, and I'm very pleased to see it expanding across America. We've just opened up our 14th state. I just saw an email. We're live in New Jersey. Very exciting.
Shout out New Jersey.
All right. So there's already questions out there to answer.
So the first question I have is actually a conversation that Mark and I just talked about before we went live. Mark, do you want to tell everyone in the audience where you recently returned from and the history of that retreat itself?
So what I was telling Emma about was I've just been to Thailand, and I went there for a specific reason, which was it's when I first started coming off my medications now 7 years ago. And I had gone there in a very difficult period in my life, I should say. And I went, I feel like a bit of a cliche to go to a yoga and meditation retreat when you're in trouble, sort of like a bit like Eat, Pray, Love, but I don't have quite the same hair as Julia Roberts. But I went there, and I did a lot of walking meditation, and I remember thinking in that many days of walking, why am I on these medications? One of the thoughts that came to my head, because I was on at that point 2 antidepressants and a couple of other drugs. I thought I'm on these drugs because I have such unpleasant memories sometimes, things that invoke shame, that invoke anxiety, that I feel like I can't handle it. That if I think these thoughts, it'll be so unpleasant, my head might turn on fire, or I might sort of melt as a person. And as I was walking backwards and forwards at that meditation retreat, I did have these thoughts, and they were unpleasant. They were unpleasant memories of things that had gone wrong in my life, things that I wish had gone in another way. But my head didn't explode. I didn't sort of burst into flames. There was something about the meditation retreat. It was very supportive. There was lovely people around. There was a wise monk. It had all the elements that you need. And I remember thinking, well, maybe I can handle these thoughts without medication. And that was the sort of moment that I decided that I would come off these drugs. And that's when I sort of started searching around for what's the best way to come off the drugs, and found surviving antidepressants and learned all about the sort of things that led to hypolic tapering. And I said, as a pledge, I will come back here and redo this meditation retreat without medications. And I thought I'll be back in a few months, because I thought, it'll take a few months to come off these drugs. But of course, it took me 6.5 years to come off my medications. And I should say that doesn't mean that everyone in the audience is going to take that long. I was on a lot of drugs, and I did a lot of work while I was coming off the drugs. I came off very slowly, I made every mistake in the book. Which is why I wrote a book about it. But anyway, I came back. It took me 7 years to go back to the meditation retreat. So I did go back, did complete my pledge. In the meantime, the monk actually that had overseen the retreat had died, which was quite sad, because I thought I might come back to him and tell him what had happened since I last saw him, but I didn't get the chance. But anyway, I feel like I've brought the issue full circle. So it was a bit of closure for me.
That's beautiful. I think we maybe had 10 to 15 people actually submit questions, Mark, asking specifically to you, what was the moment that you decided to come off your antidepressants? And was it more motivated by, awareness of the medication itself and maybe not wanting to be on it anymore? Or it had maybe more to do with wanting to know if you could navigate the feelings, emotions, and thoughts without them? And I think you actually encapsulated that quite well in your response just now.
I'll add to it. I guess that was probably the last piece in a process. I should say before that, there were a few other bits, and I'll talk about it briefly. The moment that stimulated me was a few things. One, then in my PhD, I read an academic article about withdrawal effects from antidepressants, and I found that alarming, because I thought 2 things about that. Number one, any drug that causes withdrawal effects also causes tolerance. The more you become tolerant to a drug like caffeine or opioids, the harder it is to stop. And I thought, I've now been on an antidepressant for 13 years. If it causes withdrawal and tolerance, how could it still be working? Number one. And number two, drugs that cause withdrawal aren't generally very good for you. Benzodiazepines, recreational drugs aren't that good for you. So I thought, if this drug that I'm on does that, what are its other effects? I had a number of health issues while I was on the drugs, namely fatigue, memory, and concentration problems. And in sort of searching around on these websites, I found that a lot of people had similar issues on the drugs. So I thought, maybe these drugs have caused all these health issues that I've had, and that were quite significant. They affected my ability to work. They affected my relationships, and why am I on them after 13 years if they wear off? And what else are these drugs doing? And then that sort of final piece, I guess, was, why do I need to be on them in the first place? So I guess it was a sort of process to go through.
Yeah, a lot of awareness and maybe identifying to the side of what was a side effect from being on medication versus what was more related to the emotions of what you were dealing with is like a standard effect of the human struggle, right? Which was what we talk about all the time. I think something on that note that we also got a couple of questions about that I find pretty interesting as well is a lot of people want to come off antidepressants because of the side effects. They're not, they maybe don't think that the antidepressant, like you mentioned, is doing what it's supposed to do anymore after a couple of years, but that they're still impacted by the effects of being on that antidepressant, like memory fog, dissonance, apathy, things of that nature. One of the questions that we got a couple of times, especially for the people that have mentioned that they were on antidepressants for a decade or two, will tapering off my antidepressant address the symptom, the side effects of being on antidepressants for such a long time, or will I continue to feel lethargic, apathetic, and so forth, even after I successfully taper?
It's a great question. And I think the answer is mostly yes. Yes, the side effects of the drug tend to go away if you come off the drug. I'll give you some. So you've mentioned a few examples of side effects. So some common side effects are emotional blunting, not feeling your emotions, sexual inhibition, reduction of desire, arousal, the ability to ejaculate or to have a pleasurable ejaculate. Weight gain is an issue. In the short-term studies, they don't show very big effects on weight gain, but in longer-term studies, they do. Memory issues, concentration issues, daytime fatigue because they cause disruption of sleep at nighttime. And there's nausea, there's dizziness, there's gut issues, there's a whole range. There's a very long list of side effects. I often say to people, in the drug pamphlets, in the drug packets, they have a pamphlet. What are the different side effects? I think a lot of doctors say, well, those are written by lawyers. Don't worry about them. I say to people, they're written by the lawyers. Worry about them. They wouldn't be putting them in there if they weren't significant issues. So I think it's worth reading through it. I think just make one other point. I think a lot of people don't put together these effects that they have are the side effects of their drugs. And I know I didn't. And I think it's because of the timeline. If you take an antibiotic for 6 days and you start vomiting and having diarrhea, it's the antibiotic. No one misses that. When you take a drug for months, years, or decades, and it causes some gradual onset of mental fog or tiredness, it's very hard to put it together. If you say to someone around you, I feel more tired, they say, well, you're getting older. Maybe you're stressed at work. It's very hard to pinpoint it. It's often only after people come off the drugs and those things go away that they realize, it was the drug. And I've seen that again and again. And the sort of main things I see people that go away when they come off the drugs is the emotional blunting, is the sexual issues, is the energy problems, is the concentration and memory things, and gut problems. I think a lot of people get diagnosed with things like irritable bowel syndrome whilst on these drugs because they have, there's a lot of serotonin receptors in the gut. A lot of people have effects on the gut. In relation to the person that asked that, I can't guarantee that they'll all go away, especially if you've been on it for very long term. I think it can take a while for the body to sort of rebound from it. But generally over time, they do go away. So what I hear from people who've been off the drugs for months or years is that things go back slowly to normal. I think people are surprised at how long it takes. They kind of expect, remove the drug from your system and everything's back to normal. I think it can take longer for the system to recover. I just say from my personal experience, and I'm just, one person, but a case that I know well, it's had a profound effect on my ability to concentrate and to think straight. So I think when I was on all these drugs, I had serious issues with memory and concentration to the point where, I thought I was going to go see a neuropsychologist to get an assessment. I thought something's going on here. I didn't sort of seriously think, do I have dementia? But I thought this is getting quite profound. It's having quite an effect on my ability to do my job. I'd sort of wander around the hospital with a sheet of paper, writing things down very carefully. If I lost the piece of paper, I would kind of forget what my caseload was. So it really had a profound effect on me. And that is markedly changed. You're nodding. You had something similar, or
yeah, I was very analog at that point too, and found myself writing my to-do list for the day and how to do certain tasks and making sure, especially because I was off campus, having everything packed that I needed, because I might find myself in a situation where I'm like, oh, I need to go here. I'm like, oh, but I didn't prepare for that. So mine was very much so predicated by preparation in the morning. My roommates thought it was great that I had these very detailed to-do lists every morning. I still do it now, but it's more of anything a routine of something that I got into habit. I know you too, by the way, working with you, you're a very analog person. You keep your calendar and your diary by hand. I get it. I still take a notebook with me everywhere I go for the same reason.
I mean, the analog of it, that's because I'm a geriatric millennial and you're a whip smart Gen Z. But I'm laughing while you're saying that because I did the exact same things in terms of breaking things down into steps. I actually look back and actually think it was unethical. And I got to that point. I thought it was unethical for me to work as a doctor because I was so befuddled by the drugs. I did exactly what you said. I would say, whatever, turn on the computer or go to the store, buy this, eggs, blah, blah, blah. I'd break everything down to little bits because I would get so confused. I look back and I'm actually shocked that I was able to kind of function, that I was driving, I was parking, I was paying bills, but it was so hard for me. I felt so in a fog. I don't know how I was working part-time as a doctor because I was so tired and so befuddled. And I had this idea that I had chronic fatigue syndrome. I had narcolepsy, is what doctors told me. I would say that 80% more of that has cleared now that I'm off the drugs. It's been such a profound change, in my ability to think straight. I've had a very productive few years. I think that's because, I've had a much sharper mind, much more able to concentrate.
Yeah.
And I
think
and I didn't
go ahead.
realize. I didn't realize it was the drug, I guess. That wasn't my topmost thought. So I just, and so many other people these days now.
Question 2 that relates pretty well to this that we got about an hour before the webinar as, did the side effects of being on an antidepressant initially get worse when you started tapering, even when you were tapering hyperbolically? I think that's something that we actually hear on discovery calls and even from our patients constantly is the thing that they're most concerned with that's a side effect of their antidepressant maybe getting worse, and that's why they're trepidatious about starting their taper. I'd love to hear about your experience in that capacity as well with the memory.
So you're saying the side effects get worse when they start tapering. That's the question. That's the issue that happens. Yeah. I mean, so when I hear that, that sounds a bit funny to me. And the way I make sense of it is the following. There's a bit of an irony that some of the withdrawal effects are similar to the side effects. So I think, because it doesn't make sense that a side effect would get worse when you're on less of the drug. That doesn't, a side effect is the drug is having a directly negative effect, memory, concentration, weight gain. It shouldn't get worse if you reduce it. But what can get worse is withdrawal effects. And then ironically, withdrawal effects can overlap with side effects. How is that? This is the way I make sense of it. Antidepressants inhibit certain sleep stages. So people sleep worse when they're taking antidepressants and they can feel tired during the day. So tiredness is a side effect. But tiredness is also a side effect of withdrawal. Again, I think it's because you're changing the chemistry in your brain, the balance, and that upsets your sleep. So people get a lot of insomnia and tiredness. And so I think that antidepressants can have a side effect of tiredness, and also withdrawal can include tiredness, probably for different reasons. And so I guess if you're really worried about tiredness and you come off your drug and you start to think, I'm getting more tired, you could think this is a side effect worsening. I shouldn't reduce my drugs. But I wouldn't interpret it like that. I'd interpret it like I'm going maybe a bit too fast and the withdrawal effects are becoming unpleasant. Therefore, I should go slower. But I don't think it exactly makes sense that as you go down, side effects get worse. That doesn't quite chime with my way of thinking.
So if I understand you correctly, what you're saying is if my main concern with my antidepressant as like a side effect is poor sleep, and I decide to start tapering my antidepressant and my sleep gets worse, it makes more sense that that's a sign that I'm tapering too quickly than a sign that my side effects are just getting stronger or more devastating.
Exactly.
Okay,
It doesn't make sense to be lower dose, more side effects. That doesn't pass the smell test, so to speak.
Well, this is a really interesting question that we actually got as well twice now. We know that generally people at Outro and our community here at Outro probably don't agree that people should be on antidepressants for life. Motto being antidepressants don't have to be forever. How do you feel about the statement, people can use antidepressants but should use it for the shortest duration possible?
I guess, where does this idea, it says the idea that people should be on the drugs lifelong comes from sort of two different areas. One is the explanation for why the drugs work. And number two is the kind of trials that they look at for long-term use. So I'll just start with the first one because I think that has a big place in people's minds. There's this explanation that the reason why people should be on antidepressants is because they lack serotonin. There's a chemical imbalance in their brain. If you take a drug, it replaces that, like insulin for diabetes. And if you have diabetes, why would you stop insulin? If you have a thyroid problem, why would you stop thyroid hormones? I don't know how familiar the audience is, but that idea that we have a chemical imbalance, low serotonin, was a medical hypothesis 60 years ago, but it really has become widespread because the drug companies that made these drugs spread it out as a marketing message. And so it makes the drugs sound very appealing, but there isn't good evidence behind it. So, we now know, depression is caused by our life circumstances mostly, about what's happening in our lives, stressful life events. Yes, some people are more prone to it than others, but it's not down to a chemical like serotonin that you can replace. And so that idea that we should be on a lifelong drug because of a chemical imbalance doesn't stack up to the evidence. That's point one. Point two is some guidelines do recommend long-term treatment with these drugs. I should say in America, the guidelines, the main ones there, say that most people should be on these drugs for 6 to 9 months. So even the guidelines say you shouldn't be on them lifelong. So, it's more a cultural practice people are on it, or because doctors don't know how to stop the drugs, or it's just not part of what happens. The other reason is withdrawal effects. So that's sort of obviously an important point. In studies that suggest long-term treatment, what they do is they take a group of people on antidepressants and they randomly assign them to either stay on the drug or come off the drug. And they show in those studies that people that come off their drug do worse than people that stay on the drug. Do worse means they're more anxious, they get depressed, they have panic attacks. So they say you should stay on your drug to prevent those things. But those studies ignore withdrawal effects. And so, I use an analogy. It's a bit like if you took smokers and you randomly assign them to either stay on cigarettes or come off it. People who stop smoking become more anxious and irritable. You wouldn't say you should keep smoking to prevent anxiety and irritability because we know that those are withdrawal effects. But because they've ignored withdrawal effects in these studies, they use those studies to recommend people use the drugs long term. And so those studies are flawed. They don't provide a good basis for recommending long-term treatment. And so I think that is, those are not strong arguments. And then to come back to what should people do, I think, and, there's more people around that share my ideas, that the way these drugs work is mostly by numbing people's emotions, dampening down what they feel, probably by disrupting the normal functioning of the brain. And so if you're going to use that, you might choose to use it. You might be in a terrible position and there's no other options available. But that doesn't sound like a great thing to do, long term. It sounds like you should use that as a short-term strategy, a band-aid, look for, more comprehensive, sustainable solutions that don't have the same side effects rather than use them long-term. So that's the kind of, I think, a more rational, pragmatic way of thinking about how the drug should be used.
I think a question that comes up for a lot of parents on that note as well about, let's say you're trying to be the most responsible parent to a child whose doctor has recommended that they start medication. A question that we got quite a bit in the Q&A session with Dr. Adam Arato, despite it being more focused on women in pregnancy and taking antidepressants, was actually parents who were interested in hearing thoughts from experts on how to talk to your child about the side effects that you might see of them being on an antidepressant, let's say after those 2 years. So people that have been on them, maybe for the person that submitted the question said 5 years, navigating the conversation about coming off of them. I'm sure you've actually had facilitated this quite a bit in your practice. And I think it'd be a really beautiful question to respond to.
Okay. I mean, it's I guess all the things that relate to children, are similar to adults, except it's in many ways, the evidence is even stronger that they don't work. So I guess I'd say a few things. So as it happens, we are publishing a paper tomorrow that looks at the only antidepressant that is licensed for depression in the UK. In America, I think there are laxer rules, so more drugs are licensed. But the main drug that's licensed is Prozac or fluoxetine. Because in other studies, they've shown that all other antidepressants don't have clinically important effects on depression in children. And so they're not allowed to be used in the UK. They're not recommended to be used. But they've said for a while that, well, Prozac is a bit different. It has a bit more of an effect. We've looked at all the studies that have been published and it doesn't have a different effect. It's the same as a placebo. And so even before you talk about side effects, just going back to the original reason why you're using the drugs, the evidence is weaker in children than it is for adults. I've talked probably before, the evidence is not very strong in adults. Well, it's much weaker in children to the point where none of these drugs have shown what's called a clinically important difference in children's depression. So we have called for guidelines to update to take antidepressants out of guidelines because there's no point in giving an ineffective treatment. So that's just to take a step back before we talk about, what to do with someone who's already on the medications. So if this is a question about a child who's been on medications for 5 years, how do you start that conversation with your child about the consequences and if they might come off? I guess it can be difficult, especially if you're the one that made the decision for them to go on it. There could be feelings of guilt and regret about that decision. Everyone's making decisions based on what doctors are telling them. All parents are nervous. They're going to do the wrong thing. There's a lot of pressure on parents to prescribe drugs or to have their kids prescribed. They're told, if you don't treat this, your daughter or son will fall behind in school. They'll lose their trajectory. I can see already my friends, some of whom have, teenagers, have that kind of pressure put on them about choosing medications, and they feel, unsure what to do. I'd say, well, to start off with, the drugs don't have great evidence. I think the next point is people are put on these drugs because of the problems in their lives most of the time. Mostly it's something about happening at school, happening at home. It'd be wonderful if there was a drug that you could take to take away all of those problems, but I don't think that generally makes sense. It's generally useful to go to what is the core problem? What is, bullying, family discord, drug use, issues with sexuality and identity. There are so many things to look at before you decide, I'm going to use a numbing medication. Another point is the New York Times, people might have seen a few days ago, put out a long piece
exactly,
about how antidepressants affect the sexual development of children. Does it affect, we know in animal studies, it does funny things to the way that sexual development happens. There's all these stories from young people saying they don't have the same, levels of attraction or arousal or capacity to have sexual enjoyment when they're on antidepressants during teenagehood, and it persists after they stop in adulthood. So it's very concerning. What are these drugs doing? We don't have great answers because it hasn't been looked at, but there's some worrying signs from people's experience and a question about whether it's, a long-term effect. And I guess thinking about the side effects for this person's child, it's the same as for adults. A lot of people don't put it together. If they're emotionally numbed, if they've got sexual issues, if they've put on weight, it's very hard to pinpoint it to the drug. So I suggest people talk about these possibilities. I'm not sure if that's the most comfortable conversation to have as an adult with your child about sexual side effects with the drugs. But if their doctors are not having the issues, then maybe you've got to start the conversation in some way. I sort of talked about all these things, cognitive issues, brain fog, trouble with sleep. Some young people become more anxious and more depressed on these drugs, as happens for adults sometimes. They call it tardive dysphoria or late onset low mood. So I've talked to a lot of parents that are extremely worried about their children. They sort of see the kids are getting worse, or they're not being helped by the drugs. They see side effects, and they don't know how to intervene. I think it's worth, trying to have these conversations. And then I guess talking about, going through the kind of process. If they do decide to come off, I guess all the principles we talk about at Outro for adults apply to children. Coming off quickly is not a great idea. It's the way to cause the most trouble from withdrawal effects, the most risk of having long-term effects. So coming off in a slow, hyperbolic way, coming down by smaller amounts is the best thing to do. There's not a lot of research for children, so I don't know if it's as hard for them as adults. I hope that it's easier for them because they've generally been on the drugs for a shorter period of time, but I don't know that. So I would take a cautious approach and kind of be guided by how people respond to reductions.
Yep. I just want to note everything you covered is totally to be done and recommended. And I think something else that I think too as well is perhaps mentioning that the longer you're on, I love that this fact alone, I think, has helped me facilitate this conversation a lot with adults with children or young adults in general, that the longer you're on the medication is a risk factor for how challenging the taper itself can be. So once you're ready, it's worth starting the conversation. And I kind of like that as like a motto generally with your community of people that is not necessarily to tell everyone from the rooftops, like get off of your medication now. It's if you feel ready, you might as well consider starting, because if you'll continue to feel ready 5 years from now, it actually might be more difficult in 5 years. That alone for me is some type of like, might as well consider it, especially if you're in a stable situation.
Yeah. Which I'd say three things. I mean, you're a good point. You make a good point. If you're in a terrible state of things falling to pieces in your life, it may not be the right moment to do it. That's, of course, an important issue. But I agree with what you've said. I see a lot of people who are very ambivalent about the drugs. Think, I don't know if it's helping me. I think I do have side effects. I'm not sure. I don't know if I'm ready to take a big reduction. My advice is do a very small reduction. It's better to start earlier and do things extremely slowly than put it off and do big things. So it'd be better to kind of do a 1% dose reduction. If you get a liquid of some sort, do a very tiny reduction and see how it feels, rather than wait for when everything is completely perfect to do a big reduction. And the reason I think that is, one, your point, it's better to kind of try things, but two, people have their anxiety reduced by doing the thing. They call it, you sort of, the anxiety before you do the thing is worse than the anxiety of doing the thing. Anticipatory anxiety. Yeah, so because they've tried to stop the drugs by stopping them abruptly in the past, they've had a very bad response. When they go down by 1% or 2% or 5% and they realize it's not so bad. It makes everything, easier. It makes everything less anxiety provoking. So I think it's better to start by dipping your toe in a little tiny bit, rather than working yourself up to do some big white knuckle jump is my
Totally.
advice.
On a different note, still tangentially related, I do have like a long form question that I think we don't normally share, but I think this one actually answers quite a few other questions that were submitted. So bear with me here, everyone. As a long-term user, 15 years of mirtazapine, who's tried 3 times now to get off of the medication, and now attempting for the first time to do a very cautious hyperbolic taper, I'm interested to know if at any point you ever advise someone to stay on the drug because of withdrawal symptoms maybe become intolerable, or if in your experience, it's more recommended than having someone hold is to let them hold until the withdrawal symptoms are minimized and then to continue the taper. So to summarize, do you ever recommend that someone indefinitely holds a really low dose?
It's a great question. People ask it all the time. And I guess I break it down into a couple of parts. So would I recommend that everyone should come off their medications? I guess the answer is no. Sometimes I encounter people who are in their 80s, they're fragile, they're old, they sort of know the drugs are causing them trouble, but they're worried about could they tolerate the process. And I sort of think, if you are very old and very fragile, it can be a disruptive process. You can make it very slow. Maybe you can reduce, your dose. Maybe you won't be able to get off the whole dose. So I wouldn't say for everybody you must come off the drug. It's always the right decision. Or if people are in a state of great turmoil, they're unstable housing, financial problems, they don't have the capacity to add on coming off their drugs. So I think everyone has to make a decision for them when it's the right moment, what's the balance of benefits and harms, and when it works for them. So I think I provide people a lot of information to make a decision. If this person, assuming they're not in their 80s, they're not highly fragile, they've had trouble coming off, they've tried 3 times. Okay, so like a lot of people, they've probably tried to halve the drug or quarter the drug and got into trouble. I do have a feeling that for everybody, there's a rate that works. So, I use an analogy with altitude sickness, that if you go up a mountain very quickly, the pressure drops and people get altitude sickness. And the way to avoid it is to go up the mountain more slowly. To some degree, anybody can go up, a couple of kilometers of a mountain, taking aside the physical capacity. I'm talking about just the altitude issues, if you go slowly enough. And I think that is kind of true for coming off medications. If you come off slowly enough, the process can be so, mildly disruptive that you can tolerate it. I think that people don't have a sense of how long can be. So I sort of talked about it before. I thought long originally was 4 months. I thought that's way longer than anyone I know does it. And that caused me, incredible trouble. Then I thought, okay, 9 months is long. That wasn't very easy. Then I thought, okay, 18 months. Okay, and that was too hard. Then I got to 3 years and eventually took me 6 years. And again, I'm not saying that everyone should take 6 years, and maybe people don't want to spend 6 years, but I do think that most people, if they go slowly enough, it can be tolerable. There's a small subset of people that get into incredible trouble, protracted withdrawal, akathisia. I got to say, even some of them, if they go slowly, it can get off. I mean, I am one of those people. I got akathisia coming off my drug. I thought I can never do this again. When I did do it, I did it extremely cautiously. It took me a lot longer. So I do have this sense that the vast majority of people, if they go slowly enough, can come off. And so speaking to what that guy said, yes, mostly my approach is if people get into trouble, I say pause, go back a step, wait, even a considerable period of time for things to settle down, and then go even slower. So, the most common thing I say in clinical practice is just go slower. I'm a bit of a repetitive, boring fellow, but I do see that as the main kind of determinant of who's successful and who's not.
I know I say this all the time, but I just also, for everyone in the audience too, because they're always appreciating you, want to say what a testament it is to your resilience to go through multiple taper attempts and then taking 6 years, not giving up throughout 6 years and completing it is I don't know, it just evoked something in me. Even if you do take more time, even if you hold for long periods, even with the ups and downs, I just think a lot of people find you very inspirational. I know you probably don't like to hear that, but I'm going to say it anyways.
I'll just knock it back in the following way. I mean, because that makes it sound like I was crawling through mud, like some kind of hero, things. And it wasn't like that. I wouldn't be able to do that. I think that's the whole point, that it wasn't a heroic thing.
Yeah.
I guess that's why I was able to do it, because I did it very slowly. I was able to live my life around it mostly. Sometimes I did go too fast and I got into trouble. I guess if it was 6 years of white knuckling it and, crawling through barbed wire, then yes, I would deserve this praise, but it wasn't that. And I think that's what people miss. People say to me, 6 years of suffering, I couldn't do that. but it wasn't, it wasn't 6 years of utter suffering. There was moments where it was not fun. I wouldn't do it for no reason, but it wasn't, unbearable. And I guess that's the point, that you can do things for long periods if they're not, utterly unbearable.
Other than going slower on your last taper, there's two questions here. Were there any lifestyle changes or changes to your routine, diet, sleep that you deliberately made in that attempt at tapering? Even though I'm sure too the slowness is what predicated the success there. Anything else you found helpful, and if you've maintained any of those lifestyle changes since discontinuing?
So I'll give a couple of answers to that. One, I've heard someone say that the techniques that people learn to cope during withdrawal would have been the techniques that would have prevented them needing to be on the drug in the first place. And I kind of think that's true. So when I got into really bad withdrawal, not this time, but when I tried 10 years ago and I came off in a few months, I developed what I think is sort of moderate akathisia, a lot of agitation, a lot of anxiety, a lot of terror. And I took up meditation in a serious way. I had learned it before, but I grabbed onto it like, for dear life. And I listened to John Kabat-Zinn's body scan meditation probably, 1,000 times. And I, did it completely change things. It didn't make it easy, but it was a bit helpful. I took up running. I ran, like hell. I ran until my feet bled, basically. So I did a lot of that. Did that fix everything? Not really. It made it a little bit better. And I guess these are things that I've picked up along the way, exercise and meditation, although I do that less these days. In the process of coming off, when I did it slower, I guess I've sort of become, actually, because I was so tired for years on these drugs, I sort of became, into self-help, into all this wellness stuff. So I did pick up, exercise. I did weightlifting. I did running. I sort of ate low carb things. I did a lot of intermittent fasting. And I think all those things were a bit helpful. So I got to say, I don't know if any of them, none of them have been tested in randomized trials, but I did find that intermittent fasting, sometimes I did it less, sometimes I did it more. I feel like when I did that, it made my symptoms a bit better. I felt that when I did a bit of exercise, not a lot, because sometimes I was quite tired in the process of withdrawal, it made things a bit better. I got to say though, I've forgotten the number one thing. The number one thing that I did that I think was the most effective was distraction. I've talked to a lot of people now, and some people say meditation is wonderful. Some people say it's not useful. And some people say keto diet is helpful. And some people say it's nothing. I've heard from lots and lots of people that the number one thing is distraction. And I think that makes a lot of sense to me. That was very useful for me. If I had to sit around and all I could think about was how, relatively unwell I felt, it would have made me incredibly miserable. But the fact that I had, I was working, I was doing a bit of advocacy work and research in this area, that was the best thing. And I makes me think of pain patients, chronic pain patients, which is something a bit similar, a chronic thing that you can't completely fix. It's notable that that's worse when people are falling asleep at nighttime because there's no distraction. Whereas when people get caught up at work or relationships or whatever they're doing, their pain is a bit better. And so I think of that as being that's something I really push people. Some people say to me, I'm thinking about quitting my job because I'm so unwell from withdrawal. I get it. Sometimes people are really sick and sometimes that's the right decision. But I often say, well, could you go part-time? Could you find, a volunteering job just so you're not kind of in bed or at home, 15 hours a day. So I think all those other things, intermittent fasting and a bit of exercise and mindfulness, if you're well enough, some people are too unwell to do exercise. It's all worth trying. I do think distraction's a big deal. And then as you said, I think going slowly, counts for 90% of everything, if I had to put a number on it. So
Definitely.
that's
Yeah.
my mixed answer.
For me, it was too, like when I was coming off of, for me, it was benzos, that I was having just a lot of difficulty with the nighttime activities. I found myself, like you, also just like running, being out of the house and being really, really active and sweating and getting like exhausting myself physically to feel like mentally exhausted, because I couldn't mentally exhaust myself at night. I was just still very active. Not the same as actually going really slow and taking your time with the process, but it was something that I ended up keeping up with, which we've talked about quite a bit.
And I think that, I think some people, exercise is really helpful. There's always people that say they're so unwell that exercise, makes them feel good. So I think it's a bit individual. And sort of one more thing that I'd say is I got obsessed with circadian rhythms. I was sort of obsessive about having light in the morning, dark at night, going to bed at the same time of the morning and night, because I was very worried about insomnia. At different points I had very bad insomnia coming off the drugs. And so I became like a circadian soldier, doing everything that the textbook said to do. And it was helpful. especially because I have a bit of a tendency to go to bed late at night. So I was a choir boy while coming off my drugs.
Did you did you have the red light glasses?
Not the real, I have got like a light box that I have in the morning. At
Yeah,
nighttime,
I have one too.
my lights go from white during the day to yellow at 8:30 and red at 10:15 and then off at 11:30. So it's like a natural sunset. But if you're outside my house, you see a red bulb. But that's because circadian rhythms, we weren't evolved to have bright light in our eyes at midnight. I think that causes a lot of people trouble with sleep.
Definitely. Now on a change of topic, also just to note for everyone here in the audience, closing up on 15 minutes, we always get questions about patients in protracted withdrawal. And I understand too that we always talk about how it's not a one size fits all and that it's difficult to maybe identify the exact way to best address it for each patient, even if they're on the same medication for the same amount of time. The way that it proliferates with different symptoms and the duration, severity of those symptoms will be different across patient to patient, or even when in the first time they taper, the fourth time they try to taper. I was going to ask you for the protracted withdrawal community, what is the advice that you've found to be the most helpful for them? Maybe like nervous system regulation. I mean, we can take it from any angle, but I think for a lot of the time, it just has to do really broadly with the dysregulation from your nervous system. What have you found maybe from insights with your colleagues or working with different clients that you might suggest to them to explore for themselves?
I think the first thing to say is, no one really knows what's going on. It's an awful state to be in, and there's, at the moment, there is no real ideal treatment, or any real strong evidence for any treatment. I feel for people that are in that state, I have huge sympathy. I think it's an outrage that it's not being looked at more and not being researched. And I guess, there's a few approaches, thinking about medication first before talking about non-medication things. I think there's sort of three broad, there's two main ways of managing it. One is not to take any more medications, give time for your system to heal. The second option is trying a small dose reinstatement of your drug, depending on how long ago you took it, and seeing the response. Sometimes people respond to reinstatement. Sometimes it can be very tricky using that. But I guess we're sort of talking to people maybe who, if they're asking this question, maybe they've tried reinstatement or they've decided they don't want to, and they're sort of sitting in a state of, as you say, nervous system dysregulation. I think that's a fairly, good description of what's going on. I think people hate when I say this. The main treatment is time. Everyone wants to sort of know what is a whiz-bang treatment. I think people do tend to heal over time. I've seen a lot of people go through it. A lot of people recover. It takes a lot longer than they would like or they expect, but things do improve. And then in terms of what works, look, I've seen people try everything, under the sun, from things that I've mentioned: fasting, keto, exercise, meditation, all sorts of complementary and alternative practices. And in terms of what works for a lot of people, I'm not sure I see huge patterns. I sometimes do think that things like intermittent fasting or a low carb diet can improve people. Sometimes it doesn't affect people. So I'm sort of talking here based on anecdote rather than on good trials. I've seen people who benefit from distraction. The same sort of things apply in protracted withdrawal, that even though they are in a terrible state, keeping busy in some way, volunteering, doing something they're interested in, a hobby, keeps their mind off their horrible symptoms. I've seen people that exactly do things that calm their system down. I've seen people say cold water swimming helps, or warm baths help, or lavender candles, or or relaxing music. I think people have to try. There's long lists of these sort of things on different websites, and I think people just need to go through them and try, see what works for them.
I said, yeah, exactly. To find what works for you and explore the different offerings, because there isn't going to be like a textbook of exactly what to do, like you said.
Yeah.
We're coming into the last 10 minutes, so I'm going to run through a couple of quick questions. One from Lisa in the chat. Can you make liquid form from any tablet using the ratio of 1 milligram to 1 milliliter, or would depend on the medication itself?
So, when people are thinking about how to taper, obviously some of the questions come to, what form is the best to use? And, liquids have a lot of benefit for people because they allow you to make small reductions and do it carefully. Some drugs are made by the manufacturers as liquids. So in America, a lot of antidepressants and other drugs are made by manufacturer. I guess there's some issues with them. Sometimes they have preservatives in them that people react to. Sometimes the doses are slightly different from tablets. People can react when they switch across. Sometimes people absorb them a bit differently because they're already kind of in liquid form. So there's a few things to watch out for when you transition. If you can't get a manufacturer's liquid or you can't tolerate it for whatever reason, what this person is asking about is something called an off-label option. And an off-label option means an option that the manufacturer hasn't recommended in their, sort of medication leaflet, but it's legal to do. You can do whatever you like with your tablets. It just hasn't been supported by the manufacturer. And so most tablets of psychiatric drugs, if you put it in a glass of water, will disperse and mix up. Most of them are not soluble. And so they will not form a solution. They'll form what's called a suspension. So, for example, a suspension is any cough syrup that you have in your drug cabinet that says shake before using will be not a solution where the drug is dissolved in the mixture, but a suspension where it's sort of sitting there and it drops to the bottom, which is why you've got to shake these things. So what this person has said, putting a milligram of drug in a ml of water, yes, you can do that with any drug. It may not mix properly. You might find there's lots of specks. If you shake it up, it can make things better. It's never going to be perfectly distributed throughout the mixture because it's not going to be a perfect solution. And so there are inaccuracies that come about with doing something like that, using an off-label version of a drug. Some people do it. You can use warm water. If you use more water, you can sometimes make it more soluble, but there's always going to be issues with inaccuracies. That's why some people prefer to use compounded pharmacies to get more exact capsules. But there's also, and also compounded pharmacies can also make up liquids for you. So the answer to this person is yes, but all those provisos that I mentioned.
Another question that we get often, so I'm going to try to see if I can answer this right too. At Outro, we do monthly tapers, but a lot of health coaches online tend to recommend microtapering. Something that I've learned from a lot of the patients that have come to us after doing daily micro tapers as an insight that I think is pretty useful is if you're tapering daily or reducing daily, you might actually, and you find yourself getting caught up with pretty severe withdrawal symptoms, you actually won't know what dose was probably the right one to reinstate back to. And tell me if I'm getting it wrong here, but in that case, it does make quite a bit of sense to be giving yourself more days to stabilize so that way your body can adjust to the new dose and you can see whether or not the adjustment is tolerable or not. Because if you're doing it daily, you won't know if it was Tuesday's reduction or Sunday's reduction or Saturday's reduction, which can just leave you maybe struggling a bit more to find the right dose to hold at. Did I get that right?
There are sort of different views on this because, there's sort of pros and cons to doing micro tapering versus monthly tapering. I think the reason why monthly tapering often works for people is sort of you meet a clinician, you make a decision, you get to sort of think about it. You sort of make the decision then and then come back and review it. Micro tapering is a little bit more of a kind of, you're making decisions all the time. You might want to speed up or slow down. I guess the rationale behind micro tapering is, okay, yes, you could think about it like that. You sort of made lots of little reductions. And so what was the right day to go back to? There's also a bit of confusion with monthly tapering, although you could sort of say it's the last month. But the idea should be that in doing micro tapering, you're not going quicker than you're doing a monthly taper. So if you go from, 10 milligrams to 7 milligrams in a monthly reduction, or going down by 0.1 every day, you're not actually making a bigger reduction in the month. So it sort of doesn't matter if it was the Tuesday or the Saturday that got you. You shouldn't be going down faster than if you were doing monthly reductions. So it shouldn't, people say, oh, it'll kind of build up, it'll be cumulative, but it's not going to accumulate more than making the monthly reduction. So yes, I sort of understand what you're saying, but it shouldn't theoretically be any worse than doing monthly tappings.
Totally. Another question here, which I think is a question I have as well, that I actually have never asked you. So I know there's no official clinical research on this as much as there isn't about most of the topics we've been covering in this Q&A session.
Yeah.
Have you seen in your practice that there's a difference in the tolerability for a taper based on why the person was originally prescribed an antidepressant? So with the people that might have been prescribed an antidepressant for OCD or anxiety versus depression, do you see like a significant difference in like maybe their taper schedules or how long it takes or how difficult the withdrawal symptoms are?
So the answer is no. And actually, rarely, when I normally say before every question, there's not much evidence in this. We actually did a study on this where we asked people their diagnosis and their withdrawal effects, and it didn't matter what they were on it for. In fact, it didn't even matter if they didn't have a mental health problem. So we found that people that were prescribed antidepressants for physical health problems, that means things like tinnitus, menopause, pain, had the exact same risk of withdrawal effects as if they went on it for a mental health problem. And it didn't matter which mental health problem. But I guess the proviso I would say, if someone is very, extreme, have terribly uncontrolled OCD, then of course, coming off their medication, adding on extra trouble might make things worse. So I guess if someone has in a very severe state, that could make things worse. But let's say things are pretty stable, then the answer is no, because it's about the effect of the drug on the brain, not about someone's, mental health condition. I guess I've had the experience of seeing lots of people that were put on these drugs that have nothing to do with mental health problems. I've seen people tinnitus, pain. I've sort of seen
PMS.
PMS. I've sort of seen, because sometimes people look at people coming off the drugs and they say, well, they're having a lot of trouble. They're anxious, they're depressed, but, that's the sort of people that take these drugs. Well, I've seen, killer CEOs of major companies who were put on the drug for tinnitus that have no mental health problems, who I suspect give other people mental health problems because they're so tough. And they've had the exact same withdrawal effects coming off. Panic attacks, not sleeping, turning into real basket cases. So I've seen enough different people to know that actually there's a lot, it's much more about the drug than it is about the person.
And a last question here. For people that are tapering and new withdrawal symptoms are coming up, do you typically recommend that they they go by time, let's say like tapering by every 5 weeks? But if a new withdrawal symptom comes up and they're 5 weeks after their last reduction and that withdrawal symptom hasn't mitigated, would you recommend that they just stay on until that withdrawal symptom is mitigated? Or is there any situation where you've seen that people, even through their terminal dose, or still have like 1 or 2 lingering withdrawal symptoms that had they not continued the taper, they would have actually ended up holding indefinitely?
Yep. Oh, I see. I use a traffic light system. So I basically say, so the answer was yes, I think you should hold if your symptoms are lingering, because otherwise you get cumulative symptoms. So this is a sort of idea, back to my analogy of altitude sickness. You sort of go up the mountain, you feel really sick. If you keep going up, you're going to get sicker because you're going to be adding on more altitude sickness on what you've already got. If you're already in bad withdrawal and you keep reducing your dose, you're going to get worse withdrawal. At some point, it's like a wave of withdrawal building another wave, you're going to get cumulative effects. So in general, I would sort of, this is my rough rule of thumb, it's different for everybody, get people to score their symptoms out of 10, where 0 means no symptoms and 10 means unbearable symptoms. Most people can handle 0 to 3 out of 10 symptoms. So if your symptoms go back down to 0 to 3, doesn't mean completely gone. You don't have to be, like wait till you're, dancing in the middle of the street because you're so happy. But, symptoms are tolerable. I think that's the right moment to reduce again. When symptoms are 8, 9, or 10, that's red light. I think no one should be reducing then. They should probably be going, back up to a higher dose. Then there's the intermediate, 4, 5, 6, 7. I think people should slow down at that point. I think it's a good point to hold. I see some tough guys who think they can go through it. I think that generally backfires. So I think it's better to wait for things to settle down. So yes, I've got to say, I think I'm much more inclined to hold, go slower than to push through. I think that brings out this sort of paradox where tortoises beat hares. The slower you go, the more likely you are to be successful. I think a lot of people work that out themselves. They come off too quickly, they get into trouble, they try again. And I try to, impart that to people that going slower is the quickest way to come off these drugs.
Well, on that note, I think that actually leaves people with like a general good sense of how to track their own taper, which is, if anything, one of the most important harm reduction points of these Q&A sessions, because not everyone here is an outro patient. The point actually is to be more of an open source for people, not just our patients, to be better informed about coming off antidepressants safely. And I think what you just mentioned about tracking it by withdrawal symptoms rather than by time necessarily, of like, every 5 weeks I have to go down, is a great final statement actually to land here on. Thank you so much, Mark. It was nice to see you.
Thanks, Emma. See you again next time. Bye.